So we're going to see for two sessions, I think. First session will be on myopathies. The second session will be on muscular dystrophies. These are not same. You have to broach there.
Yes, I can.
So we are going to look at myopathies today. And in the second class, probably we will look at the muscular dystrophies. What is a myopathy? What is a myopathy? It should not have motor neuron disease or peripheral neuropathy or neuromuscular junction disorder. They are separate. There, the muscle is not functioning because of the motor neuron problem or peripheral neuropathy or NMJ problem like myasthenia gravis and other things. So, first of all, you have to exclude motor neuron disease, peripheral neuropathy, muscular junction, neuromuscular junction, and any of the corticospinal lesions for the muscle dysfunction. No neurological, no peripheral nerve, no NMJ. Now, what exactly is now myopathy? Weakness of the muscle, predominantly proximal. Myopathies are generally proximal. And plus minus pain may be there, may not be there, and a muscle enzyme elevations will be there, very important, and systemic manifestations depending on the etiology. One other thing that you have to can add there, which is not listed by me, is absence of sensory symptoms. Okay, if I am looking at a patient who has got progressive muscular weakness, either acute or chronic, and with elevated muscle enzymes, plus minus pain, plus minus systemic manifestations, without sensory involvement, I am probably looking at a myopathy. Of course, I would have excluded motor neuron disease, peripheral neuropathy, and NMJ problem. That should be very clear. This is a conceptual understanding. So, any weakness must first be localized into one of the four levels. So, what are the weaknesses that can look for? One is anterior horn cell. Any muscle weakness can be an anterior horn cell lesion, like the ALS, amyotrophic lateral sclerosis, where there is a combination of how do I exclude the other four, the other three? Anterior horn cell dysfunction will have upper motor neuron lesion, the corticospinal tract, and lower motor neuron lesion, that is the ALS. ALS is amyotrophic lateral sclerosis, where you have an upper motor neuron lesion and also a lower motor neuron lesion, either bulbar or spinal. Presence of mixed spasticity and brisk reflexes, wasting and fasciculations and weakness. In a same patient, some groups of muscles are wasted, fasciculation is there, weakness is there, lower motor neuron cells. Spasticity, brisk reflexes in the other group of muscles. There is no sensory loss there also. This is the ALS. Next one is SMA. What is SMA? Spinal muscular atrophy, a hereditary disorder due to degeneration of the anterior horn cells, commonly caused by a mutation or a deletion of the SMN1 gene, leads to pure lower motor weakness. There is no corticospinal involvement. There is no sensory, hypotonia, muscle wasting, reduced or absent reflexes, sensory functions are preserved. This is a pure spinal muscular atrophy. The difference between ALS and SMA is ALS is a combination of upper motor neuron and lower motor neuron. Suppose pure spinal muscular atrophy is purely anterior horn cell disease. This I have to exclude to look for myopathy. Then the peripheral neuropathy, we have already looked at several types of neuropathies. So I have not anything detailed here. Examine for peripheral neuropathy. Usually there will be sensory symptoms, usually bilateral, usually Glavin stocking type, Usually maybe motor and also combined with sensory mononeuritis and all that we have discussed. Now, MNG, that is the neuromuscular junction problems. There are two diseases there. One is the myasthenia gravis, the other one is the LEMS. What is myasthenia gravis? It is an autoimmune disorder of the muscular junction. Usually antibodies against the postsynaptic acetylcholine receptors. ACHR is acetylcholine receptor. Postsynaptic acetylcholine receptors are blocked or not available for function. They are MuSK type of receptors or LRP4 type of receptors. Causes fatigability and weakness, commonly ocular and bulbar. Myasthenia doesn't involve upper limbs, lower limbs very much. It usually involves the ocular muscles and the bulbar muscles, and it is a fatigable weakness. Initially, the contraction is okay, but if you ask him to sustain the contraction, the weakness will become more and more weaker. Ptosis may be a common feature of myasthenia gravis. Now, LEMS. What is LEMS? Lambert-Eaton myasthenic syndrome. Okay, Lambert-Eaton myasthenic syndrome is an autoimmune disorder of the neuromuscular junction. Antibodies against the presynaptic voltage-gated calcium channels. Earlier, it was postsynaptic acetylcholine receptors. Here, it is presynaptic voltage-gated calcium channels, P and Q type. VG is voltage-gated calcium channels, VGCC. Causes proximal weakness. Autoimmune symptoms will be associated. Facilitation will be there. What is facilitation? If you ask him to do the movement initially, he is not able to do. If you go on doing the same movement, he is able to do it. Unlike in myasthenia, initially is all right, but slowly it declines. In facilitation, it gradually it improves, often associated with SCLC, small lung cell carcinoma. So these are two important neuromuscular junction.
Paraneoplastic.
Pancreas tumor.
Paraneoplastic.
Yeah, paraneoplastic syndrome. SCLC. This is a component of the paraneoplastic syndrome. So two conditions related to the muscle myoneural junction. That is there. One is this myasthenia gravis. The other is the LEMS. Okay. Now we have ruled out the peripheral nerve. We have ruled out anterior horn. We have ruled out anterior horn and corticospinal also. We have ruled out motor neuron disease and LEMS. Now we are with the muscles. So I'm tabulating here for your convenience. Hallmark of clinical localization, myopathy, neuropathy, NMJ. Myopathy feature weakness, myopathy proximal more involved than distal, neuropathy usually distal is more involved than proximal, neuromuscular junction, proximal only, fluctuating weakness will be there. Sensory symptoms are absent here, neuropathy there present, myoneural junction absent. Reflexes preserved until very late in myopathy, they are reduced in the early phases, usually preserved in the neuromuscular junction. Wasting very late in myopathy, very early in neuropathy, minimal in neuromuscular. Fatigability, not typical. Fatigability is ask him to sustain the moment, he will not be able to do it. For example, if I ask you to hold the hand like this, you can hold for a reasonable length of time. In case of myasthenia gravis, it drops, particularly eyelids. Okay, there is no fatigability in neuropathy, and NMJ also there could be fatigability. Very typical of NMJ fatigability. Okay, CK often very raised in myopathy, normal or mildly raised in neuropathy. It is absolutely normal in the myoneural junction. Okay, so we have now seen the difference between these things in a clinical way. Now, why proximal weakness in myopathy? This may be asked to you by in the questions in the Vivo. You say proximal weakness. What is the reason? Why proximal muscles are involved? What is the reason behind that? Proximal muscles contain a higher portion of type 2 fibers. These are called the fast twitch fibers versus the type 1 fibers, which is there in the peripheral part of the body. Large bulk muscles for anti-gravity function. These are fast twitch. Immediately they have to act. For example, quadriceps, hamstrings, biceps, deltoid. These muscles contain type 2 fibers. These are anti-gravity functional. So there is a high metabolic demand on them to walk, run, to lift weights, to do anything. The proximal muscles, lot of demand is there. Okay, these are classified into shoulder girdle, hip girdle, neck flexors. These are the three types. Most systematic, metabolic, inflammatory myopathies preferentially affect either the shoulder girdle or the hip girdle or the neck flexors. When somebody asks you why proximal muscles, they contain a fast twitch type 2 fibers where large bulk muscles are involved and high metabolic demand is the reason for the proximal involvement. Therefore, typical pattern will be difficulty in climbing the stairs. How does the patient say? Yeah, suppose he has to climb stairs, he will not be able to climb because that they involve the proximal muscles. Raising from squatting, ask him to sit on the floor and get up. That is called the Gowers sign. What is Gowers sign? Can you describe it? Gowers sign.
They'll take support. Person is not able to get up from the squatting point.
How do they get up?
They'll take support. They'll take the support of the walls and loading.
On the knees first of all. They will hold the knee and then they'll be climbing on that. If it is a child, if they are sleeping, ask them to get up, they roll to one side. After rolling down, they try to pull their legs and then try to bend forward, hold the hands, and then slowly catch something with the hands and then get up. This is a typical Gowers sign. I'll show you a video also of the Gowers sign. Okay. And then what are the common things? Climbing the stairs, raising and squatting, Gowers sign, and then combing the hair and lifting overhead objects. Ask him to lift the suitcase from the ground to the overhead. He will not be able to do it because of the proximal muscle weakness. He may be able to lift it from the ground because distal muscles are involved. If he has to lift it onto the aircraft cabin there, then he will not be able to lift it. Okay. Symptom analysis. It's a deeper learning. Onset, acute, subacute, and chronic. Distribution, proximal versus distal, symmetric versus asymmetric. Neck flexors, very important, strongly suggest inflammatory myopathy. If neck flexors are involved, there will be inflammatory myopathy is possible. Bulbar, ocular involvement, think of NMJ junction. That is myasthenia gravis. But some myopathies do it, the myotonic dystrophy, mitochondrial, they also involve the bulbar and ocular. Okay. Now, so next one is the weakness profile. And then where are we? Difficulty in climbing chairs. And then the weakness profile we have seen. And then the pain profile we have to see. Pain profile. Myalgia is very prominent in viral myositis, polymyositis, dermatomyositis, statin myopathy, rhabdomyolysis. So if you have a myopathy with pain, you have to think of these things. Not only has got muscular weakness, he or she has got associated pain also, myalgia also, viral myositis, polymyositis, dermatomyositis, autoimmune diseases, statin myopathy, and rhabdomyolysis. These are the 4 conditions of myopathy with pain. Okay, minimal pain, muscular dystrophies. Muscular dystrophies we'll discuss in the next class, and this is the pain is very minimal in muscular dystrophies. Another thing is you have to look for exercise tolerance. Important clue to metabolic myopathies, particularly, the glycogen storage diseases, lipid diseases, mitochondrial disorders, the exercise tolerance will be very poor. And myoglobinuria, that means the urine will be Coca-Cola colored after exercise. So ask them to pass the urine before the exercise, and again after the exercise. If you again ask them to pass the urine, it will be because of the rhabdomyolysis. There will be metabolic myopathy and myoglobinuria will be present. Now, what are all the things we have seen till now? So we said that Myopathy is a disease where you have excluded the peripheral neuropathy, where you have excluded the motor neuron disease, where you have excluded the
Neuromuscular junction.
neuromuscular junction disorders. Neuromuscular junction disorders are myasthenia gravis and then the these are the two conditions. Now, this will have proximal muscle weakness mostly, may be pain, may not be pain, muscle enzymes are elevated, associated features may be there. Then localization, we have already seen anterior horn cell, which has got a combination of permotor and lower motor, and you have only the lower motor neuron lesion. This is called the spinal muscular atrophy, that we know it is a genetic condition. Then the peripherals we have already discussed at length, that handout is with you, and neuromuscular junction, myasthenia gravis, usually the ocular muscles and the bulbar muscles are involved. It is a postsynaptic acetylcholine receptor defect, and then fatigability is the feature. LEMS is the Lambert-Eaton myasthenia syndrome, where you have not only the problem is with the presynaptic voltage-gated calcium channels, and how to differentiate between myopathy, neuropathy, and NMJ also we have seen. Now, what is the reason for proximal weakness? The reason for proximal weakness is because of the type 2 fibers or fast twitch fibers. The fast twitch fibers are located in the bigger muscle groups, like the proximal muscles, the pectoral girdle muscles, the pelvic girdle muscles, and the hamstrings, and the quadriceps, and of course your deltoid, your biceps, triceps. These are the shoulder girdle, hip girdle, and neck flexors. Therefore, so how does the patient come to you? He comes with a difficulty in climbing the stairs, raising from the floor, Gauss sign, combing of the hair, and lifting weights overhead. Symptom analysis: is it acute, subacute, or chronic? Distribution: is it proximal or distal? Is it symmetric versus asymmetric? Neck flexor involvement strongly suggests inflammatory myopathy. Is it bulbar weakness or the ocular weakness? Usually neuromuscular junction. Another thing is myalgias, very prominent myalgias. If they are present, viral myositis, polymyositis, dermatomyositis, statin myopathy, rhabdomyolysis, or muscle weakness and pain. No pain, muscular dystrophy. Exercise intolerance, important to rule out metabolic myopathies. Myoglobinuria, cola-colored urine after exertion is due to metabolic myopathy and rhabdomyolysis. Now, clinical examination. Okay. Muscle bulk, that is the nutrition we call. Muscle bulk, proximal wasting is there or no. 2. Pseudo-hypertrophy. These are called the dystrophic myopathy, which are going to see in the next class. Pseudo-hypertrophy. Why it is called pseudo-hypertrophy?
Fat deposition will be there.
Hmm?
Typically, muscle hypertrophy will not be there. It will be fat deposition.
Yeah. And also, this is not a functional muscle. See, normally the muscle is bulky in an athlete, he'll have a power. Here, muscle is bigger but no power. So that's why it is called pseudo-hypertrophy. Scapular winging, facioscapular humeral dystrophy, contractures, dystrophies, and metabolic. These are the, in the inspection, what you look for. Muscle bulk, pseudo-hypertrophy, scapular winging, contractures. Okay, done. Power testing. After the inspection, you start testing the power. What you have to test in myopathy is not that you examine from head to toe. You should concentrate on these 4 things. Shoulder abductor, like what? This moment. So give him a resistance and ask him to abduct the shoulder. And even higher. This is a shoulder abductor. Hip flexors. Ask him to flex the hip joint, the thigh onto the abdomen. And hip extensors. These 2. Neck flexors, like this one. Neck flexors, and ask him to sit up erect. This is trunk muscles. To ability to sit erect, or the trunk muscles. That will be weak. So nutrition, what you have seen, the bulk of the muscle, pseudohypertrophy, scapular winging, and then contractures. In the testing, what you are seeing, shoulder abduction, and then hip flexor, followed by neck flexor, and then trunk weakness. This you will see. Functional test that you are going to do is stand from a chair without support of hand. For example, if somebody is there like this, say for example, a person has to get up from the chair. Normally, people with muscle weakness, they will use the support like this. Slowly they will get up. Normal person should be able to get up like that without the support of the chair with the hands. So ability to get up from the chair. And then Gowerstein, which you have already discussed. Gowerstein is child will not be able to stand directly from the lying down position or sitting position. Child will stoop forward, hold the floor with both the hands, then slowly lift one hand and try to hold the wall and some object, then lift the other hand and then slowly gets up. And another thing is heel toe walking is also very important. This is also called tandem walk. Heel toe walking also is important. So these are the functional tests. So nutrition you have examined and power you have tested and functional testing. Heel toe walking is like here. And it should be in a straight line. So tandem. Same thing as tandem. And this is faulty in case of ataxia also, in muscle weakness also. So first with eyes open, then with eyes closed. And always be on the side of the patient so that they don't trip. Okay. So that is about the heel toe. Reflexes. Reflexes are usually preserved in a myopathy. This you have to remember. In myopathy, reflexes are preserved. Whereas in case of anterior horn cell, reflexes are lost. In case of amyotrophic lateral sclerosis, reflexes are exaggerated in some muscles. Sensory examination rules out other things. Very important, in myopathy, sensory is not affected. Confirms myopathy rather than neuropathy. Neuropathy also produces muscle weakness, but there is sensations are affected there. So what are the three important things I keep in mind? Tandem walk, Gowerstein, standing from a chair without support. Then reflexes I have to see, sensory I have to see. Then classification of myopathies. What are the classifications? So inflammatory myopathies, drug-induced myopathies, under-inflammatory, polymyositis, dermatomyositis, immune-mediated necrotizing myopathy, also called the IMNM, immune-mediated necrotizing myopathy, very fast progressing disease. Inclusion body myositis, IBM. These four are the inflammatory myopathies. What are they? Polymyositis, dermatomyositis, autoimmune diseases. Immune-mediated necrotizing myopathy, inclusion body myopathy are also inflammatory myopathies. Then drug-induced one. What are the drugs which can cause muscle weakness or myopathy? Common drug being statin myopathy, steroid myopathy, alcohol myopathy, colchicine myopathy, antimalarials, particularly quinine. Quinine is known to produce myopathy. Okay. Statin myopathy, though it's not common, one must understand what is statin myopathy. Steroid myopathy, statin, alcohol, colchicine, antimalarials. Now, any endocrine causes can produce, yes, hypothyroidism and myopathy, hyperthyroidism and myopathy, Cushing's myopathy, hyperparathyroidism, vitamin D deficiency with osteomalacia. Now, what are the classification? Number one, inflammatory polymyositis, dermatomyositis, immune-mediated necrotizing myopathy, inclusion body myositis. Drug-induced, statin, steroid, alcohol, colchicine, antimalarials. Endocrine, hypothyroid, Cushing's, hyperparathyroid, vitamin D deficiency. Then you have got the metabolic causes. Metabolic causes, particularly the glycogen storage disorders, lipid oxidation defects, mitochondrial myopathy. Then, of course, you have got the muscular dystrophies, Duchenne's, Becker, limb-girdle, myotonic dystrophy, facioscapulohumeral, which are a separate entity, which are genetic entities, which are muscular dystrophies, which we'll see in the next class. There will be definite muscular weakness there also. Then you have got what are called the channelopathies. That is, potassium channels are affected, or hypokalemic periodic paralysis. I used to have 2-3 patients of hypokalemic periodic paralysis, and hyperkalemic periodic paralysis, though rare, it can also occur. Anderson-Tawil syndrome and malignant hyperthermia with susceptibility. These are called channelopathies. Finally, you have infective myopathies, viral myositis, dengue fever, and also particularly chikungunya fever. Chikungunya, you would have seen some cases in the last few years. Severe myopathy, severe pain, break-bone fever. See, when dengue is called break-bone fever. So the pain is so severe, out of proportion to the fever. Pyomyositis, that means where there are abscesses in the muscle. Small abscesses form. This is called pyomyositis. And trichinella spiralis infection can also produce a painful infective myopathy, which is a parasitic disease, trichinella spiralis. Okay, how do I approach further diagnosis? Stepwise investigations. First step. First of all, I must confirm that I am dealing with a myopathy. How do I do that? There must be muscle weakness. There must be some progressive nature, no sensory involvement, reflexes are preserved, no wasting is usually seen. And there is no other upper motor or lower motor neuron signs. There is no sign of neuromuscular junction involvement. I am dealing with myopathy. Then what do I do? CK. Serum creatinine, CK is creatinine kinase, a key marker. AST-ALT will be elevated. AST-ALT are two types are there, liver type and muscle type. So if you are looking for AST-ALT elevation in the muscle, from the muscle, you have to say I am looking for muscle AST-ALT. Then the lab will look for that subtype of that AST-ALT, LDH and aldolase. So what are the markers? CK, AST-ALT, LDH and aldolase. How do I interpret the CK? Normal CK, steroid myopathy, endocrine myopathy. CK is mildly elevated, chronic dystrophy, very highly elevated, inflammatory neuropathy, immune inflammatory neuropathy, very high, or rhabdomyolysis, where the CK value will be more than 5,000. Then what is the next test available? Electromyogram, EMG. EMG, so myopathic pattern, small amplitude, short duration motor unit potentials. MUP, so motor unit potential. This is a small amplitude potentials will be there. Early recruitment will be seen. Neuropathic pattern, denervation will be seen. Fibrillations may be there. Reduced recruitment with large units. Then first what I did, I have done the serum muscle serum enzyme. Second, electromyogram. Third one is the autoimmune workup, because some of the myopathies are autoimmune in nature. How do I do? ANA, anti-nuclear antibody, myocyte-specific antibodies, anti-Jo1 antibody, anti-MI2 antibody, anti-SRP, anti-HMG coenzyme reductase. HMG is what? Hypoxanthine hydroxymethyl, that is the statin metabolism. HMG is the statin metabolism enzyme. HMG coenzyme reductase, HMG-CR, and MDA5, and anti-TIF1 antibody, which is usually associated with malignancy. Of course, CRP and ESR also may be elevated. So first thing is, after the physical examination and testing, you have to do the CK, AST-ALT, LDH orders, and then you have to do the electromyogram. Then, of course, you do the autoimmune workup, particularly look for ANA and myocyte-specific antibodies like anti-Jo1, Mi2, SRP, HMGCR, and these are the antibodies. Then imaging. What imaging I should do? MRI muscles, detect edema and inflammation. And imaging is not going to be very useful, unlike in neuropathies, unlike in spinal cord compressions, unlike in diseases arising above, where imaging has a great role. Here, imaging has got a very minimal role, and it will be useful for ultrasound guided or image guided biopsy taking for imaging use. Muscle biopsy is the gold standard. You have to take the muscle biopsy. So, perivascular atrophy and perivascular inflammation, that is dermatomyositis. Dermatomyositis is perivascular atrophy, perivascular inflammation. Polymyositis, endomysial inflammation with CD8 cells more. IMNM necrosis and minimal inflammation. IBM, that is inflammatory myopathy, removed vacuoles and amyloid deposits. Now, we have to discuss something about the polymyositis and dermatomyositis. So, polymyositis is subacute proximal muscle weakness. Neck flexors are mostly affected. Dysphagia is possible. There is no rash. Polymyositis, subacute weakness of the muscle. Neck flexors are affected. Dysphagia is possible. No rash is seen. Lab value CK is elevated. TMB myopathic picture. The contrast of that is the treatment for this, of course, is large doses of steroid and steroid-sparing agent, methotrexate and azathioprine. This is polymyositis. Then dermatomyositis, muscle weakness plus rash. If a patient with muscle weakness without rash, it is polymyositis. If there is rash, it is dermatomyositis. Okay. Heliotrope rash. What is heliotrope rash? Heliotrope rash is violaceous periorbital rash and eyelid edema. Eyelid edema will be there and periorbital violaceous rash will be there. Very characteristic of dermatomyositis. Heliotrope rash and Grattan papules. What are Grattan papules? These are also violaceous scaly papules over the MCP joints and the PIP joints. This is the metacarpophalangeal joint. This is the proximal interphalangeal joint. This is proximal interphalangeal joint, metacarp. This is metacarpophalangeal joint is this one. PIP is this one. This is TIP, TIP, terminal interphalangeal joint. So mostly MCP and PIP are involved. There will be scaly papules, which are called the Grattan papules. Shaw's sign. What is Shaw's sign? Shaw's sign is a photo-distributed violaceous rash. And that means wherever there is, the sunlight exposure is there you see the rash. Over the shoulders, upper back, and typical dermatomyositis picture. Mechanics hands. What are mechanics hands? Very rough, fissured, hyperkeratotic changes on the fingers and the palm, strongly suggestive of antisynthetase syndrome in inflammatory myopathy. So, how do I differentiate polymyositis and dermatomyositis? Both are autoimmune disorders. Both have muscle weakness. Polymyositis, subacute proximal muscle weakness, neck flexors are affected. Dysphagia may be there. Rash is absent. CK is elevated and then EMG is myopathy. Whereas when I come to dermatomyositis, rash is the feature, violaceous violet color rash, heliotrope rash around the eyelids with eyelid edema, Grattan's papules over the MCP and PAP joint, Shaw's sign over the back and shoulders, and very typical dermatomyositis. Mechanics hands, where the hands are rough, fissured, and hyperkeratotic. Now, most important is dermatomyositis is a disease of elderly life. Polymyositis occurs in the younger people. So you have to also look at the especially older age of onset. You should consider dermatomyositis. Okay. Immune-related necrotizing myopathy, IMNM, immune-related necrotizing myopathy, very high yield now. That means, if you test for it, you have more cases coming up. Suggests when severe proximal weakness, CK is very, very high, can be triggered by statins. It may not be statin myopathy. Statin can act as a trigger for IMNM. That means the statin acts as a hapten. What is a hapten?
Iron also. Hapten is antigenic response.
See, antigens produce antibodies and produce, the antigen antibody reaction. Certain drugs act as a hapten. Means the drug goes and sits on a particular cell, and together they produce an antigen and it's recognized as autoimmune antigen. So the statin acts as a hapten and then produces immune-mediated necrotizing myopathy. Okay, the mechanism is immune mediation. Statin is an incidental trigger for that as a hapten. Okay, antibodies. Well, if you look for antibodies, you will see anti-HMG coenzyme reductase antibodies. HMG coenzyme, hydroxymethylguanine coenzyme, hydroxymethylguanine coenzyme reductase inhibitor, anti-SRP. These are the two antibodies you find. How do you treat? Steroids, IVIG, immunosuppressants. This is this particular disease is an immune-mediated necrotizing myopathy. You have to put them on steroids, IVIG, okay, immunoglobulin IV, and then the immunosuppressants like methotrexate and other drugs. Inclusion body myositis, IBM. IBM, most important differentiator, clinical pattern, usually elderly, quadriceps weakness, finger flexor weakness. So there, the quadriceps muscle and the finger flexors, a rare combination. Inclusion myopathy, inclusion body myositis, that is elderly people, quadriceps weakness, finger flexor weakness, usually asymmetric, is a IBM, that is inclusion body myositis. Here, the important part is IBM looks like polymyositis, but behaves like a dystrophy. That means appearance-wise, it is like polymyositis. Progression-wise, it is like a dystrophy. There is a poor response to immunotherapy. Then you can have steroid myopathy and chronic steroid use. Proximal weakness will be there, minimal pain, CK normal, EMG normal. So, history of steroid use is there, proximal weakness, minimal pain or absent pain, CK is normal, EMG is normal. Okay. Occurs in chronic glucocorticosteroid exposure and in ICU patients. Statin myopathy spectrum. There could be only myalgia. Suppose somebody is receiving statin for a good length of time. So let's say you started statin day before yesterday. Today myalgia cannot come. At least 3 weeks you have to use statin to say it is statin myopathy. So what some people will do, they will take statin today, tomorrow they come and say, doctor, my sort of cough muscle is paining. That is not statin myopathy. Minimum of 3 weeks exposure should be. Okay, myalgia will be there to start with. Then there will be toxic myopathy where CK is elevated. If only myalgia is there, CK is normal after statin exposure of 3 or more weeks, it is stage 1. Next one is toxic statin myopathy where CK is elevated, and IMNM is immune-mediated necrotizing myopathy where the antibodies to HMG-CR are there, persistent weakness even after statin is stopped. Okay, now come to endocrine myopathies. Hypothyroid, proximal weakness, cramps, CK elevated, delayed reflexes and relaxation. That is because of the mixed edema or the hypothyroid. Here, the delayed DTR will be a feature. Whereas in case of hyperthyroidism, you have proximal vessel weakness, CK is normal, tremor may be there, tachycardia may be there. Vitamin D deficiency, proximal muscle weakness, bone pains are typical, waddling gait also you can see. Metabolic myopathies, that is, these are always exercise induced. So exercise intolerance you can see in metabolic myopathies. Metabolic myopathies are precipitated by exercise, whereas other myopathies they are at rest only itself. Whereas if it is a metabolic myopathy, at rest they are normal. If you ask them to do an exercise, very early fatigue, cramps will be there, episodic rhabdomyolysis may be present. What are the different disorders there? Glycogen storage disorders, symptoms occur in early exercise, lipid oxidation defects, symptoms after prolonged exercise or fasting, mitochondrial disorders, multisystem involvement will be there. Then there is a myopathy emergency is there, which is called the rhabdomyolysis. That means muscles are being lysed like anything very fast. Myalgia, weakness, cholauria, that is myoglobinuria. And then labs, massive increase in the CK, hyperkalemia because potassium is released from the muscle cells. Acute kidney injury is a feature of rhabdomyolysis. Management, aggressive IV fluids, manage the electrolytes, dialysis if it is severe. Okay. Now, what are my tips for differentiation? Myopathy versus neuropathy. Neuropathy, distal sensory symptoms, reduced or absent reflex. Myopathy, proximal weakness, sensations are normal, reflexes are preserved. If you pointedly, they will ask you in the exam, how do you differentiate? How do you say it is myopathy and not neuropathy? Myopathy, proximal weakness, sensations normal, reflexes are present. Neuropathy, distal sensory involvement, and then reduced reflexes will be there. And motor weakness is secondary to the sensory effects also. Or how do you differentiate myopathy with NMJ, neuromuscular disorder? Neuromuscular disorder, fatigable weakness. That means starting it will be there, slowly it drops. You'll be able to open the eyes, keep it for a few seconds, then slowly the eyelid drops. It could be ocular or purpur. Myopathy, the weakness is not fatigable. There is no sort of fixed weakness will be there. And myopathy, CKs are elevated, whereas in NMJ disease, CK has got no business to become elevated. So how do I go about in the bedside? First of all, you confirm that there is proximal muscle weakness. First step. Second step is no sensory symptoms or signs. So I have excluded peripheral neuropathy and the proximal muscle weakness. Then check CK. If CK is very high, it could be inflammatory, necrotizing, or abdominal. CK is normal, steroid myopathy, endocrine myopathy. Determine the tempo, how it is going on, acute versus chronic. Chronic means endocrine and dystrophies. Acute, viral, rhabdomyolysis, familial periodic paralysis. Then do an EMG, that will guide you, and MRI guided biopsy if still unclear. One-liners you should remember. Normal reflexes plus proximal weakness, high CK, myopathy. Reflexes are normal, weakness is proximal muscle, CK is elevated, myopathy. Finger flexors are affected, quadriceps also is affected, elderly person, inclusion body myopathy. CK is normal, proximal weakness is there, steroid use is there, steroid myopathy. Persistent statin associated weakness with CK, high CK, anti-HMCG, necrotizing myopathy triggered by the hapten of the statin. Exercise induced metabolic myopathies. Okay, now I am going to ask you some questions. Read the question and give the answer. Okay, read the question.
52-year-old woman has progressive difficulty climbing stairs and lifting object over it for 2 months. She has neck flexor weakness, no skin rash. The CK is 8,000 international units per liter. EMG shows myopathic potentials and ANA positive. So dermatomyositis cannot be because there are no cotton papules in the heliotrope.
Dermatomyositis will have some dermal changes.
Dermal changes.
There is no heliotrope rash, there is no Grattan sign, there is no shawl sign, and those things are absent. So dermatomyositis is ruled out. Second one is
polymyositis, chances there, sir. ANA positive and difficulty in climbing stairs and lifting over it, shoulder. Inclusion body myositis, it will involve finger flexors and
steroid myopathy, history of steroid.
steroid not be elevated and proximal weakness with
Yes.
steroid intake.
Pain will be
Hmm?
pain. Steroid myopathy, they will have.
Steroid myopathy cannot be here because there is no history of steroid use, no here. So one thing is what we have to see, there is a progressive myopathy. What is the typical presentation? Climbing the stair problem. Okay. Yeah. Okay. So stairs climb. What are the typical ways they present? Climbing the stairs, getting up from bed, lifting objects onto above the shoulder, and then these are the typical features. She has got those things. Presentation is 42 years. Okay. Dermatomyositis is even elderly. Polymyositis is middle age group. Woman, progressive difficulty in climbing stairs, lifting objects over the head, and then she has neck flexor weakness, also very important. Okay. So, no skin rashes are there. That's very important to rule out the dermatomyositis. CK is moderately elevated. EMG shows myopathic pattern. Okay. The answer is B. Polymyositis, the proximal weakness, neck flexor involvement, high CK, normal this one. No rash. Then look at this
Progression around eyelids and scaly. Cotton dermatomyositis.
one.
Heliotrope rash and cotton papules so dermatomyositis.
So 50-year-old woman presents with proximal muscle weakness, difficulty in swallowing, discoloration around the eyelids, and scaly papules over the knuckles. So which is pinning my diagnosis to dermatomyositis. Why not CIDP? CIDP is chronic inflammatory polyneuritis, polyneuropathy. But here no sensory symptoms are reported. Okay, and CK is elevated. There is no business in CIDP for the CK to be elevated. And muscle weakness is proximal. They are also proximal only. CIDP also proximal weakness. But presence of rash and then CK elevation, scaly papules, and this is the diagnosis is dermatomyositis. Okay. So heliotrope rash, Grattan papules on the knuckles with myopathy is dermatomyositis. Now, look at this one. Dermatomyositis are. See, already dermatomyositis diagnosis given. Which of the following is most appropriate next step? Dermatomyositis is associated with malignancy. So you should screen for paraneoplastic disease, malignancy. Nerve biopsy not required. Oral calcium, what it will do? Stop statin, is not taking statin at all. Where is the question of stopping statin? So look for malignancy. Malignancy screening, dermatitis in old age has significant malignancy association. Now, see this one.
Develops progressive proximal weakness. CK is even after stopping statin, weakness persists and critical illness very high.
Okay. Now, there is a history of statin use, proximal muscle weakness is there, and the weakness is persisting in spite of stopping treatment of statin. CK is very high. If it is toxic statin myopathy, it will be there at the time of usage. Once you stop it, if it is there, it is immune triggered statin being acted that has caused. It's called anti-HMGCR, immune mediated necrotizing myopathy is the answer. And of course, not the CIDP and not inclusion body myositis. Persistent severe weakness, very high CK after stopping statin, that is called the IMNM. IMNM is, what is IMNM? In immune mediated necrotizing myopathy. Okay. Yes, yes, yes. Progressive muscle weakness is there. Severe disability is there. CK is very high. EMG is showing irritable myopathy. And muscle biopsy shows necrosis with muscle minimal inflammation. Necrotizing myopathy, isn't it? So that means anti-Jo1, anti-SRP, anti-MI2, anti-acetylcholine. Anti-acetylcholine will be there in case of myasthenia gravis. So anti-Jo1 and anti-SRP, anti-MI3, all are muscle and this one's only. But when there is necrotizing picture in the muscle biopsy, you must consider anti-SRP.
Flexion is wrong. So
Quadriceps weakness with finger flexion. This is a typical combination which occurs in inclusion body. They have got quadriceps with finger flexion. Very typical of inclusion body myopathy. CK may be elevated, may not be elevated. So why it is not polymyositis?
Polymyositis will have proximal muscle weakness, like
Climbing the stairs, lifting up, neck flexors, those will be affected. Dermatomyositis will have same picture, associated malignancy, and of course the skin rash will be there. So here it is inclusion body myositis because the weakness is affecting quadriceps and finger flexors. Okay. Now you see.
No pain, normal,
Patient is using strong dose of prednisolone, 20 milligrams of prednisolone every day for her SLE, and she developed muscle weakness. Okay, such a weakness is called the toxic steroid myopathy. If it is inflammation, immune mediated, it will not resolve after stopping the treatment. Whereas here this will resolve after stopping the treatment. So the answer cannot be polymyositis. Yeah, IMNM also is not the answer because IMNM is triggered by steroid, this one, statin, but not continuing there. So hypothyroid myopathy. This is a typical steroid, and IMNM is not statin triggered. It is statin triggered and not steroid triggered. Here she is taking steroid. That is why it is steroid induced myopathy. B is the answer. Proximal weakness, chronic steroid use, normal CK. That is steroid induced myopathy. Now this we will be able to easily say. Muscle cramps, proximal muscle weakness. She has weight gain and constipation. Reflexes are delayed. Weight gain, constipation, delayed reflexes, elderly woman, 40-year-old woman, muscle cramps, proximal weakness. All are pointing to endocrine disease, particularly hypothyroid myopathy. Why not hyperthyroid?
They'll have
Weight loss.
There will be weight loss and there will be diarrhea, not constipation, and then the muscle DTRs will be brisk, not delayed, not delayed. Why it is not polymyositis?
because there is no proximal, I mean,
Muscle cramps are there, proximal muscle weakness, and other features of endocrine disorder will not be there in polymyositis. Why not? Why not? It is myasthenia gravis. Fatigability will be there. Okay. What is second wind? Do you have any idea? Second wind feature? Fatigability is initially the muscle will be all right, but if you continue the muscle to be used, fatigue. The second wing, what will happen is initially it will be weak, but as he does the work, it will settle. Okay, it improves. Okay, the answer is B. Then next one.
35-year-old male has weight loss, tremor, palpitation, proximal weakness, hyperthyroidism.
You see, male member, 35-year-old, tremor, palpitation, proximal muscle weakness, hyperthyroid myopathy, unlike the hypothyroid. Why not it is CIDP?
CIDP will not have palpitations, tremors,
And he will have sensory symptoms. There are no sensory reported in this. So polymyositis is out of question. And then hypothyroid it cannot be. So hyperthyroid is the answer. Okay. You see here?
2-year-old woman has proximal muscle weakness and diffuse bone pain.
Hmm.
She has difficulty in climbing stairs. Examination shows waddling gait. CK is normal.
Yeah. See, bone pain, waddling gait, proximal weakness, proximal muscle weakness are typical of vitamin D deficiency. Okay.
9-year-old woman intense exercise, severe myalgia, and
photo covered during after exercise.
aggressive IV fluid.
CK is elevated 45,000.
CK is 45,000.
Rhabdomyolysis.
Rhabdomyolysis. This is a muscle emergency.
Aggressive IV fluid.
IV fluids. The IV treatment management will be IV immunoglobulin, high dose steroids, aggressive IV fluids, start on pyridoxine. Which one is important? Out of all the
Aggressive IV fluid and treat hyperkalemia.
aggressive IV fluids and treat hyperkalemia. Not high dose steroids. Not. Okay. This is a rhabdomyolysis. Answer is C.
Young man experiences cramps, muscle pain,
Second
minute on starting improves after resting, and then resume activity. Second one phenomenon. He has recurrent episodes of myalgia.
This is called second wind phenomenon.
Muscle pain. Myocardial cells.
This is young man experiences cramps and muscle pain within minutes of starting the exercise. Okay? And he improves after resting and then can resume the activity. So you give him little rest, again he can continue. That is called the second wind phenomenon.
Episodes of myalgia.
Carnitine deficiency, McArdle's disease. Usually this sort of the metabolic myopathies, like McArdle's disease, myophosphorylase deficiency. What is the problem in McArdle's disease?
Muscle myophosphorylase enzyme will be deficient.
What is the use of myophosphorylase? It has to convert the glycogen into glucose. How does the muscle is a very big bank? It is a reserve bank of liver and muscle are the reserve bank of glycogen. This they don't have an enzyme to convert the glycogen into glucose. That is why you will not be able to exercise. Normally, when you exercise, the muscle glycogen is converted into glucose and utilized. This man doesn't have a chance to convert the glycogen into glucose. So much it's not available for exercise. Give him rest again, it recovers. Again, he will be able to do. This is called the second wind phenomenon. It's very typical of McArdle's disease or myophosphorylase deficiency. That is B. So lipid then next one you see 24.
24-year-old man develops episodic myoglobin after prolonged exercise or fasting.
Hmm.
Baseline strength is normal, CK is normal between attacks. Most likely causes.
What is happening? CK is normal between attacks. After prolonged exercise or fasting, he is developing myoglobinuria, episodic myoglobinuria. Baseline strength is normal. CKD is between attacks.
So dermatomyositis, it cannot be because no dermat features, sir.
Most likely call is CPT2 deficiency, dermatomyositis, IBM, myasthenia gravis. Myasthenia gravis, episodic rhabdomyolysis after fasting and exertion, it suggests a lipid oxidation defect. CPT2 deficiency is a lipid oxidation. McArdle's is the myophosphorylase, glucose lipid problem. Dermatomyositis must have rash. Inclusion body myositis, the typical picture of this and this will be there. That is not there. And myasthenia gravis, it will be a progressive weakness. All are excluded. Okay. So the answer here is must be A, episodic rhabdomyolysis. So next one.
Exercise intolerance, doses after amblyopia,
Very typical
myasthenia
myasthenia gravis. Ophthalmoplegia, bulbar involvement, and then the ocular involvement, episodic weakness, and then exercise intolerance. What is exercise intolerance?
After
After doing some
The
activity,
little exercise activates the disease. That's why typical diagnosis is mitochondrial myopathy, hyperkalemia, CIDP, steroid myopathy. Most likely diagnosis is what? Mitochondrial.
lactic acid, cholesterol, some
Yeah.
melas.
Now you see next one. Sudden generalized weakness, not proximal muscle. Okay? And he had a heavy carbohydrate dinner and sudden weakness in the previous night. He had heavy carb. Reflexes are reduced during attack. Sensations are intact. Serum potassium is 2.4. Hypokalemic. Sudden occurrence, generalized weakness, and then comes and goes. Hypokalemic periodic paralysis. Potassium value is 2. Treatment is rest in bed and then start infusing the potassium. And evaluate for the hypokalemia. What is the cause of hypokalemia? You have to evaluate. Next one. What is the answer? Hyperkalemia, 5.8 milligrams is the potassium, and the weakness lasts 15 to 30 minutes after rest also. Okay, that's a hyperkalemic periodic paralysis. This is very important.
35-year-old man, doses, reflexes normal, normal weakness worsens with repeated activity and improves after rest. With activity, it is worsening. After rest, it is myasthenia gravis.
Polymyositis doesn't improve with rest. That likewise, IMNM also is not like CFD. CIDP will have sensory things. Polymyositis is proximal weakness without there won't be any ptosis. In polymyositis, no bulbar involvement, no ocular involvement. Whenever there is a face involvement, immediately it excludes the diagnosis of polymyositis. Polymyositis doesn't affect the face at all. So very important. So this is how you have to fatigability, ocular involvement, normal CK, NNJ disease and not a myopathy. Okay. And this is all about the myopathies. Next time we will have what is called the muscular dystrophy spirits. Right? Okay. We'll stop here.
Okay.